Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Hi friends, welcome back to Endocrine Matters. Okay, I'm just going to start by saying this. I find it completely awkward and narcissistic to talk about myself. Truly, I'd much rather talk about hormones, the broken healthcare system, or metabolic health, literally anything else. But a colleague and friend recently said to me, Arti, your journey is actually super inspiring and people need to hear it. And since a guest had to reschedule last minute and I already had a recording spot today, and I guess I know my story better than anything else, here we go. I'm going to talk about myself today and my journey, and hopefully you'll find pieces in it that inspire you as we go along. So as you know, I'm Dr. Arti Thangudu. I'm an endocrinologist and founder of Complete Medicine, which is a direct care endocrinology practice, and also founder of Hey Healthy, which is an employer-based direct contracting practice for patients struggling with diabetes or other endocrine conditions. We work with employers to take care of their employees. I'm based in the Houston area, but we serve patients all over Texas via telemedicine. We also take care of patients in Kansas, Wisconsin, and Oklahoma via telemedicine. And today I want to tell you guys how I got here, why I practice the way that I do, and why I believe endocrinologists need to lead the future of metabolic health. So my story actually starts at age around 3. My journey into medicine, specifically metabolic health, started long before I ever realized it. My first memory in life is standing in a hospital room at around 3 years old. I don't remember much, but my dad had just had a massive heart attack. And I remember being tiny. I think I was wearing a blue jacket, and I don't really remember much else. I really didn't understand much then, but I did understand the fear that comes with experiencing such a dramatic illness at a young age. My dad was only like 37 or 38. Thankfully, miraculously, he survived, and today he's still one of the most important people in my life. And then there was my grandfather who had diabetes when I was growing up, and we lived in a multi-generational family. He lived with us for part of my childhood, and I was one of the little kids who hid his cookies so he wouldn't sneak them. I helped him do things like cut his toenails. I learned how to prick his finger to check his blood sugar early. Gosh, what if he had a CGM? I can only imagine how much easier that would have been. So he taught me my multiplication. I helped him manage his diabetes. And I really learned the family side of metabolic disease long before I learned the medical side. Fast forward, for college, I went to Northwestern right outside of Chicago, and I majored in journalism. I was a journalism major and pre-med. Luckily, I had some credits from high school, so I was able to complete this all in 4 years. I think my parents would have lost my mind if I took longer than that. My dad told me I needed to have a degree that I could get a job with at the end of 4 years in case I didn't want to go to medical school. So practical. And he actually suggested journalism because I thought I wanted to be an English major. I thought I was really into British literature and that I wanted to major in English and biology, and ended up I wasn't really good at either one of them and didn't really like either one of them. So I happened to be in college with like this amazing journalism program. Just meant that I had to like reapply for college, and they didn't really take transfers, but I told them that they wouldn't be upset that they let me into their program, and luckily I convinced them to let me into the journalism program, and I loved it. And I had no idea that this choice would change the entire trajectory of my medical career. But it does make perfect sense now because I love people's stories. During my internship, my fiance, now my husband, would jokingly call me the queen of the social history because while everyone else wanted to focus on lab values and imaging studies, I wanted to know those things, but I really wanted to know, who are you? What's your life like? What matters to you? People are just so interesting. So in medical school, I actually thought I was going to be a surgeon until the OR taught me otherwise. In med school, there's this idea that if you want to be happy, you pick a surgical subspecialty. My mom was an ophthalmologist too, so that's really all I knew. And, in surgical subspecialties, that's where like the prestiges, the good lifestyle, and money are. But standing in the OR, watching patients under anesthesia, all I could think about was, I can't wait for them to wake up so I can talk to them. So probably not the best personality fit for a surgeon or anesthesiologist. So during my residency, I found endocrinology, and I do and did love the pathophysiology, but mostly I love the patients. Endocrine patients need my time, my ability to educate them, teach them about not just their disease, but things that they can do to help them. Endocrinology requires continuity of care, a relationship, compassion. That relationship, I think, is a game changer for endocrinology patients and people living with diabetes. And that's really where I thrive and what I love doing. But after my fellowship, I started working in a traditional practice, and this almost broke my soul. After fellowship, I joined the largest private endocrinology practice in the country, and I was seeing up to 35 patients a day. All were complex, all deserved real time and attention. And I quickly realized that the system does not allow me to practice at the best of my abilities, nor at the best of my compassion. And I really did try to change things internally. I tried to advocate for my patients. I tried to rework the processes. I tried to change how things were done, but the answer was always, no, you have to see more patients. No, that's not reimbursable. No, you can't call a patient and give them the result of their thyroid ultrasound because then you won't get paid for that. That's not the right workflow. And at the same time, my patients were suffering from conditions and complications that I knew I could prevent or improve if I had the time and the patients had access to me when they were at home or at work or outside of the four walls of my clinic. And I quickly realized that the system was not working for my patients. And honestly, it wasn't working for me either. My infant son, who is almost 8 now, was falling off of his growth curve pretty quickly after I returned to work. My live-in nanny and second nanny were raising my kids. My joints hurt. I was having headaches, and my husband was working nights. It was crazy. And it wasn't the life I dreamed of. And I believed that I was smart enough and could work hard enough to get a better life for myself, my family, and my patients, where we could all be happier and be together. And everyone thought I was crazy when I decided to change something. I was only a couple of years out of my fellowship, but I did do what a lot of people told me was impossible. I built a new system for myself and for my patients, and that was within direct care. So I learned about direct primary care, which was growing at that time and still continues to grow. And I thought that endocrinology would be a good fit for a similar model. And I actually think that direct care is an option that can save medicine in a lot of ways. It can save many patients both illness and time and money, and it can keep more physicians in the game for longer and keep physicians in love with their jobs and in love with their patients. And I certainly am both of those things. So direct care puts patients first. It puts patients in front of the insurance company. An ugly thing about medicine that we don't talk about is the customer is the payer. And when the payer is the insurance company, well, it's not the patient anymore. And when the person that we're trying to serve isn't necessarily the payer, things get very murky. And the patient no longer is at the center of the interaction. I know that physicians are trying really hard to be patient-centered in the traditional insurance model, but they're not the boss. And because 70% of physicians are employed now. So even if within the four walls of the clinic, the doctor is keeping the patient at the center, the system is not. the system is focusing on profits and how they can extract the most money out of that patient interaction. Direct care also gave me and gives other practitioners in this setting independence to practice ethically. No one tells me what medication I should prescribe based on some insurance algorithm. Of course, we do respect patients' insurance algorithms, but I can tell the patients what I think is best for them and then work with them closely to get the best pricing on their medications. Sometimes we can't get what we think is best, but oftentimes we can with a little bit of creativity. Also, how I practice and spend my time with patients isn't dictated by somebody else. My schedule is created by me. So if a patient needs 30 minutes, that's what they get. If they need an hour, that's what they get. If they need 2 visits in 1 week, guess what? That's what they get. So I really love that I get to be the one who decides what my patients need, and I don't have to follow restrictions put on me by somebody who has never seen a patient in their life. Now, another really big thing is moral injury. Moral injury is not burnout. Burnout says the problem is the physician. And believe me, physicians are used to working really hard. We've done residency, we've done fellowship, we've worked nights, we've worked 24-hour calls, 30-hour calls. Like, we don't get burnt out by seeing patients. Moral injury, on the flip side, says the problem is the system. When we know what the patient needs, but insurance says no, or a hospital administrator says no, or says, no, you can't have that much time with your patient. Those are the situations when done over and over and over again, and we don't have control over creating a scenario for our patient that we think they deserve. That is what causes moral injury, and direct care enables me not to have that moral injury. I feel like I can practice with integrity. And, sustainability for physicians is important. So many physicians, especially women physicians, are leaving medicine altogether because it's not practical with the way healthcare is going to stay in. It's not that we don't want to stay in medicine. We desperately do want to stay in medicine, but the traditional system is pushing us out. And unless we start to seek other models of care like I have, we will lose physicians in a country that already has a massive physician shortage, especially in the case of endocrinology and primary care. Doctors can't take care of patients if they themselves are drowning in paperwork. And direct care really restores that physician autonomy, time, and joy in practicing medicine. This is the most joyful career I could ever imagine. Taking care of others, a career that's in the service of others, is just so joyful, but it doesn't feel that way when we don't get to do that in the way that we think is right. Another reason that I have chosen direct care is because of transparency, and I learned quickly that patients are being price gouged at every corner in the system. For example, why should a hospital charge $3,000 for a lab test that I can get a patient for $6 in cash? That $3,000 is through their insurance and is what the patient owes out of pocket because they haven't met their deductible. Why should an MRI cost $1,000 with insurance but $250 with cash? Patients deserve transparency, and transparency really does bring pricing down. That's what we've seen with GLP-1 receptor agonists in the recent news. And direct care gives them transparency in pricing, not only in the physician visit, but also with negotiated labs and imaging studies, transparency in every possible way that we can. Direct care gives me control, and that's not control for the sense of my ego, but with control comes responsibility. And when the physician has control, the patient gets better care because we know that is our responsibility at the bottom line, to take great care of our patient and to help our patient. And that having the control to deliver that care is very, very, very important for the patient and also for the physician. So I also love telemedicine. When I first started my practice, I was fully in person. I started my practice in 2019, but even as a fellow, I had done some research and quality improvement projects in telemedicine and connected technology-based care with CGM. And then in March of 2020, the world all changed because of COVID. And with direct care, I was able to move into telemedicine quickly, literally overnight. I just told my patients we're going to go virtual, and they were all super, super grateful. And I was as well, to keep themselves safe and all of us safe. And then in 2021, I moved from San Antonio to Houston. COVID was still going on. People were still comfortable with telemedicine. Some clinics were opening up at this time. But, I thought, okay, well, I started my practice and built it up in 2 years. I'll just have to do the same thing. But most of my patients from San Antonio stayed with me, pretty much all of them. And nobody wanted to go back into person, to in person, and they didn't feel like they had to. They told me, we've been seeing you for a year with telemedicine. It doesn't make a difference to me if you're at a computer sitting in Houston or San Antonio. And they didn't want to change. They love the convenience, the access, the lack of commute, the flexibility. And now I firmly believe that telemedicine is not the future of diabetes care. It is the present. And we endocrinologists, we have to lead it, because we're the only people in this space who actually know how to treat diabetes best. So the data shows that intensive blood glucose control reduces all-cause mortality, heart attacks, microvascular complications, macrovascular complications. We need to have intensive glucose control. And we have decades of evidence showing that endocrinologists achieve better diabetes outcomes than primary care. And I know that our primary care colleagues are doing everything that they can. That is not, I'm not trying to put anybody down, but endocrinology training is so deeply, I wouldn't say diabetes is the only thing that we learn, but we spend so much time on diabetes. We literally track every sugar on our inpatients. We know people's sugars like the back of our hand. Yet 85% of people living with diabetes never see an endocrinologist because access is terrible, because wait lists are months long, like the average wait time is 3 to 6 months, and because the US is short thousands of endocrinologists, and this has to do with reimbursement. Endocrinology is a preventative specialty, and the insurance model does not reward physicians for prevention. It rewards procedures. And endocrinologists don't do many procedures outside of thyroid biopsies. Endocrinology is actually the lowest paying specialty in all of medicine. And even in many areas, endocrinologists get paid less than primary care doctors despite 3 more years of training. So most doctors will say, well, I can spend 5 to 6 years of training to become a surgeon, orthopedic surgeon, and make 2, 3, 4 times as much as an endocrinologist. Why would I become an endocrinologist? Which perpetuates the shortage despite the need. Medicine is the one place where the laws of supply and demand don't add up, because the structure of reimbursement and pay is so obscure. But telemedicine does help bridge that gap. It helps us reach more patients. 75% of US counties don't have a single endocrinologist. And we now have evidence that telemedicine lowers A1C, improves adherence, reduces travel burden, increases patient satisfaction, supports rural communities. I actually had the opportunity to work with a cohort of retired policemen and firefighters where I studied their outcomes. So in the same clinic with the same staff, same resources, under in-person primary care, A1C actually increased by 0.25%. But under my telemedicine care, literally the only change was me. And I'm really not trying to toot my own horn here. I'm just saying what happens when you engage an endocrinologist in a supportive setting with patients. The average A1C dropped by 2% on average in the same patients. These patients were able to get by on less insulin, some of them completely coming off of insulin. They had less hypoglycemia, less low blood sugar, and a 100% satisfaction rate with telemedicine. So if you happen to be an endocrinologist listening, track your data. I have tracked my data since I was a fellow. Track your data, and I promise you, you are achieving similar outcomes. I am not like doing anything crazy in my clinics that you haven't learned in your training. But this is a huge reason why diabetes care is failing. Diabetes is so complex that society has forgotten it's a life-threatening, highly complex disease. So let's say you have an ear infection that's not getting better. Your primary care doctor is going to be pretty quick to send you to an ENT because ENTs have availability and you can probably get in within a couple of days or maybe a week. But since endocrinology is so difficult to get into, even if your diabetes is uncontrolled or your A1C is high for years, you're not going to be sent to an endocrinologist most likely. People come to endocrinology when they're on dialysis or they've already had all of their toes or their foot cut off. It's like ridiculous. Early intervention really is where we can prevent these complications. So many people think that they have a touch of sugar. I've heard that term way more than I would like, but they are told they have a touch of sugar until that touch of sugar becomes a touch of a heart attack or a touch of dialysis, a touch of an amputation. I'm being facetious there. There's no touches of those. They're just there or not. And that's when the system wakes up. We would never let an unresolved ear infection go untreated by a specialist for decades, but we let diabetes go unmanaged for years because there is no access. Like I mentioned, 75% of US counties have no endocrinologist. I've had other physicians tell me, like, we don't even try to get into endo anymore because it takes so long for patients to get in that they give up. Wait times are 3 to 6 months. And even when patients do see an endocrinology clinic, sometimes they're seeing a nurse practitioner or a physician's assistant or associate, depending on the state you're in. They have different names, which is fine. These are great providers who our system needs, given the volume of patients who need help. However, some primary care physicians feel like, okay, if I send my patient to see an endocrinology specialist and they're seeing somebody who doesn't have the amount of training that even I do, why would I even do that? And we talked about why there's such a shortage of endocrinologists, despite endocrinology being probably the most needed specialty in medicine right now. And also in traditional endocrinology clinics, since reimbursement is so low, there's such a high patient load. Remember, I was seeing 35 patients a day. That means about 5 minutes per patient. So we don't give the patients the support they truly need with these complex decisions. People call clinics and wait hours on the phone on hold to get a voicemail that isn't answered for weeks. Messages go unanswered. So patients are struggling with complex insulin regimens alone, prior authorizations not being correct, not getting their medications. And this is not care. This is, I don't know what this is, but it's not care. And this is why I rejected the traditional model. I love my direct care clinic, but I understand that there are patients who don't have disposable income and can't pay out of pocket for an out-of-network provider. And about 5 years ago, an employer group asked me to help them with their retirees who had uncontrolled diabetes or diabetes that was difficult to control. And I totally had imposter syndrome. I wondered, why me? They failed primary care. What can I do? But 3 months later, I knew exactly why. Time, expertise, and access led to patient transformation. In this group, average A1C dropped by more than 2%, and in the very poorly controlled people living with diabetes with a starting A1C of above 9%, they reduced their A1C on average 3%, and many of them were well controlled with low risk of complications within just a few months. 85% of these patients lost weight, and hypoglycemia, so low blood sugar rates, actually fell. And patients felt empowered. They were jazzed about their new lifestyle, changing the way they eat, exercising. We have this idea that patients aren't going to do what we tell them, so why even bother? I have seen over and over and over again that is not true. They just don't have the support they need. They don't have the time and relationship with their doctor to trust them to engage in the things that they ask them to do. Or the doctors don't even have time to talk about what they can do to prevent complications or prevent disease. These patients were the least likely candidates for improving their health, the people that the system had given up on. And they exercised, they changed their eating habits, they stayed out of the hospital. None of them in 5 years went to the hospital due to a diabetic complication. And then when COVID hit, we moved to telemedicine, and the results stayed just as good, and in some ways even better. And the patients loved it, even patients who are older, who you might assume are not as great with technology. And that experience shaped what I decided to do with direct contracting with employers. That experience of telemedicine enabled me to see that I could safely increase my reach to patients in counties further away in Texas and even in other states, and contract with big employers, citing the evidence and results that we had achieved in this population. Now I want to talk a little bit about the system, what broke the system, and why we must change it. There's a couple of things that have really made our system profits-driven and not patient-centered, and have driven physicians out of private practice, because private practice is not sustainable for a lot of physicians. And it wasn't broken by accident, right? There are people who are profiting off of the system being the way it is. And trust me, they're not the physicians or patients. So one, EMRs killed private practice. There was the HITECH Act that forced expensive EMR adoption. Small practices couldn't afford it. So I don't know if you remember, when I was a kid, there used to be medical charts, like paper charts, and there was a room for all of these charts. Later, those charts all went away and they turned into an electronic medical record, which does have some great benefits, but it became much more expensive to run a private practice using these EMR solutions that cater to billing more than patient care. And so these private practices had to sell their practices to hospitals. What happened from there? Well, hospital consolidation destroyed competition. Hospitals bought practices so they could charge something called a facility fee for everything. So this is hundreds of dollars added to a hospital bill or a clinic bill. Even when you see the same doctor in the same clinic, they do the same things. Just because it has this big hospital name on the front door now, they charge something called a facility fee. And now a simple office visit can cost 3 times or more than it did previously, the same exact thing. Administrators, not doctors, now run healthcare. 70% of physicians are employed by big health systems or even insurance companies, some of them. And administrators are paid based on revenue. They don't get patients based on outcomes. They're not delivering outcomes. So how much money they extract from each patient is more valuable than a patient doing well. A patient staying out of the hospital actually pays less. So the motivations are maligned. And fee-for-service. So fee-for-service is when a physician or a practice gets paid for doing something, doing more, not necessarily doing better. So ordering more tests. There is no financial incentive to prevent chronic disease in the healthcare system as it is in the insurance model. And there is plenty of incentive to do procedures after a disease is progressed. So preventing cardiovascular disease through lifestyle, diet, medications, things like that, not reimbursed well. But when that patient goes to the cath lab because they've had a heart attack, well, that pays very well. And that to me is quite grotesque, honestly. And medical training is wonderful in a lot of ways. It teaches us so much, but it is very hierarchical. Attendings abuse medical students and residents. It can be humiliating. And this system really kills curiosity and humanity. The culture is toxic, and unless we look that in the eye and change it, it's going to continue. And by the time physicians are out of training, they don't have the same humanity that they did at the beginning, or many don't. Medicine rewards martyrdom, giving yourself up. It does not reward innovative thinking, thinking out of the box. And sometimes it even punishes compassion and time. So when I was a fellow and I was about to leave, I was getting an evaluation from our program director, and she actually told me, like, in a sort of condescending way, you can dance circles around your patients and get them to do whatever you want them to do, but that's not important. What's important is that you pass your boards. And I did pass my boards, but it was just such a odd thing to me to say. But I do think that is the mindset of a lot of people in medicine who are training physicians who are coming up. And the other thing is academic medicine. Okay, I don't have a problem with academic medicine. I think that there's a lot of good things that happen in academic medicine, and I'm so grateful for my training in academia and access to all of the patients and the disease processes that I got to see. But academia does sell a myth of righteousness. But academia benefits financially from their indigent care programs, like, and 340B programs. They actually benefit from certain forms of price inflation and bureaucratic control, and they still pay physicians less. And yet they make physicians feel like if they go into private practice or do something outside of academia, that they are breaking some sort of moral code. But that's not true. Taking care of patients in whatever setting is a good thing. There's no right or wrong way to deliver compassionate, high-value care. And I think that's a cycle that we need to break. The problem is people who are in academia have often only been in that setting. And so if you are a physician in training, I really think getting access to varied practice settings is really important as you make decisions about your career. The other thing that we don't talk about much, but we're actually talking about much more given the news cycle, is that insurance keeps Americans broke. And we think that insurance is this thing that protects us, that our insurance card is this credit card that somebody else pays the bill for. But that is not the case. If you've ever actually been sick or actually had a medical bill, you learn pretty quickly that you still have to pay a lot despite paying premiums every month that are very high to get care and to get your insurance to cover anything ultimately. So employers shoulder massive premium costs. It's actually typically the second line item after salaries and wages for most employers. And because the cost of healthcare or health insurance is not healthcare, the cost of health insurance is so high, employees get stagnant wages. It's not just like employers are paying this without taking it from somewhere else. And then patients still get surprise bills. And insurers profit from denials when they can't profit off the transaction. This is not a system that is built for health. It's a system built for revenue, and insurance is calling the shots now. They've gotten so powerful. So I do believe that direct care and telemedicine are the future of medicine in a lot of cases, endocrinology for sure, and it aligns incentives with outcomes. It gives us transparency, affordability, physician autonomy, patient access, better outcomes, human connection, which is what makes medicine a joyful career. And it gives me and others in this space the ability to practice ethical medicine. Patients deserve time. Patients deserve humanity. Communities deserve access to good care, preventative care. Employers deserve and need cost control to take care of themselves and their employees and their bottom line. And I believe that diabetes deserves expertise. Okay, so yes, this was awkward to record, but I hope it gives you insight into why I do what I do and why I believe so deeply in rebuilding endocrinology and metabolic healthcare from the ground up. We, patients and physicians, can lead this revolution. We must lead this revolution because nobody's doing it for us. Because metabolic health is the heartbeat of America's future. Everybody struggles with metabolic disease at some point in their life, whether it's in themselves or their family members or a loved one. So thank you so much for spending this time with me. If you've made it this far, thank you for letting me talk about myself for so long. And if this resonated, please share the episode with a colleague, a patient, or a friend who needs hope that better care is possible. I'm Dr. Arti Thangudu, and this is Endocrine Matters. See you next time, and let's keep disrupting what's broken together.